Okay, so this is a 70-year-old female with a giant cell arteritis. Okay, so main points, you can see that the arch is dilated, the head vessels are pushed over here. You have a large ascending arched thoracoabdominal aorta. Now moving south, it's a little quick, but I know the video is not the greatest, but you can see here us passing right by the viscerals and renals, and then it tapers, the infrarenal narrows again before going off into the iliofemorals. Okay. So the step one for OR planning is patient selection. So one, is there an indication for surgery? And I think we can all agree there is. Two, is the patient operable? And she didn't really have much medical history, so I think she is. So the main question we have before us is what are the alternatives? So the exciting thing about aortic surgery is that there are so many ways of tackling any given anatomy, any given problem. And the key is to be able to customize your approach to the patient rather than shoehorning a patient into a given technique. So there are advantages and disadvantages to open, endovascular, and hybrid techniques, and it's important to consider all of them when you're choosing your approach for the patient. So this is data, administrative data from Ontario, published by Dr. Roca and Dr. Uzunian, comparing outcomes for open and endovascular TAAA surgery. So you can see on the left here that there is an upfront cost to open surgery that you don't see as steep a drop off for endovascular, which is in red. But then the hazard is less steep over time, whereas your rate of death is steeper for red, which is endovascular. And by the time you're 6 to 8 years out, it's actually pretty much a wash between the two techniques, with a hazard ratio of 1.09. And both of them combined is worse than the general population. That's not to say that two techniques are equivalent, though. I would say that these are two very different populations, actually. So when we look at recent TGH data, that's from the last few years, we can see that the typical open patient is someone who's young, so 57 only, has a quarter of them have connective tissue disease, not that much COPD, not that much coronary disease and diabetes, and they're primarily extent 1s and 2s. On the other hand, in the same time period at TGH, this is the endo population. So average age of 75 years old, so quite a bit older. They have more COPD, more coronary disease, 38%, 42%. These are not super healthy patients. And we do more extent 3s and 4s. So how do we choose which patient for which technique? Well, they're quite different. So for open surgery, as you can imagine, this is maximally invasive surgery that we're talking about. And even if it goes absolutely perfectly with zero complications, recovery time, no doubt, is very lengthy. So when we counsel a patient, we're talking about at least 3 to 6 months before they're feeling like themselves, even in best case scenario. So it's a very large physiologic toll. That's not to say that endovascular surgery is a walk in the park. These are very large surgeries as well. That's why I put significant physiologic toll. So even for the smoothest cases, you can still have significant AKI, you can still have things happen for sure. For open surgery, grafts are mostly available off the shelf, and it's important to remember for endovascular repair that CMDs take 2 months to get. So if you have a patient, an urgent patient that's an inpatient, it might not be feasible for you to use that, and you may have to use other off-the-shelf endovascular grafts, and they may or may not fit your patient anatomy perfectly. Open surgery is less dependent on ongoing imaging surveillance, not doesn't mean you don't have to do it anymore, but when it comes to endovascular surgery, you better ensure that your patient is very reliable, able to come back for frequent imaging, because reintervention is quite common, and you need to check in on those bridging stents and so on. Open surgery requires excellent baseline lung function. Endovascular surgery, less dependent on baseline multi-organ function, but not dependent on either. Connective tissue disease is more or less contraindicated for these endo TAAA repairs. And so these patients tend to have open surgery. Open surgery still remains the most versatile, so they have fewer anatomic constraints. You can really make almost any anatomy work, including with chronic dissections. Chronic dissections are absolutely feasible with endo TAAAs, but they do have unique challenges that to know about. So going back to our case then, so when I saw this patient, she had no important comorbidities. And I think you guys could appreciate that you're not going to be able to land this any device proximally anyway well. So I thought that we should go for open repair. And this is really the crux of the talk. We'll spend the rest of the talk talking about open strategies. So this is the recipe that I'd like to leave you guys to think about when you approach an open case. So the first question is, where is your proximal suture line going to be? Where's your distal going to be? How are you going to manage the branches? These are your visceral vessels, your celiac, SMA, your renals. Are you going to be implanting any intercostals or lumbars? How are you going to manage that? And very critical to thoracoabdominal surgery is the management of end organs. And there are many strategies for tackling that. So proximal repair then, obviously the aneurysmal extent will dictate how proximally you go. You're going to try to go until there's normal aorta to sew to. You also have to consider room for clamping and sewing. So as you know very well from the proximal side, when you do aortic surgery, if you put a clamp there and then you do your ascending repair, you're leaving many centimeters behind of native aorta. So if you go to the back end of the aorta and you apply the same concept, that's exactly the same idea. So if you're planning to clamp and sew, you have to plan for all that room as well. So whether there's room for that will determine whether left heart bypass will be possible, or even partial cardiopulmonary bypass versus a need for circulatory arrest, which would allow you to take the clamp off. And these are similar mindsets to the proximal aortic surgery. So I think it's easy for you to translate what you already know from doing proximal aortic repairs to thoracos. If for instance, if this is a dissection that you're dealing with and you apply a clamp and you look at it and it's crowded and it's full of a complex dissection there, that might make your anastomosis quite complex as well. So that might be another reason why there's no room for clamping and sewing. And is there a very crowded arch? So is there no room between the subclavian and left common carotid for you to apply your clamp? And these are the considerations to keep in mind when you're deciding whether or not you have room for your clamp. If the arch is frankly aneurysmal, then so there is no room to clamp and sew. A circ arrest also looks like you're going to be sewing to frankly aneurysmal tissue. Then you may have to consider doing another stage before the thoracal repair. So first stage conventional versus frozen elephant trunk repair. If the arch is not so bad and it's really primarily the thoracoabdominal aorta that's aneurysmal, then perhaps you can in fact sew to the proximal descending and leave yourself a reverse elephant trunk for the future. So moving on to the distal anastomosis. Again, the same idea where the aneurysmal extent will obviously determine where your suture line is going to be. But if it's very, very extensive, then the question is, how can we limit our repair? So on the right here, you can see Caselli published his data just on extent 2s. And you can see here that extent 2s does worse than extent 1, 3s, and 4s, and in terms of survival over time. And all of that cost is in the early operative period. Then the curves are rather parallel, but this is a much more extensive surgery. So you have this drop off in mortality early on. So if you can avoid a full extent 2 repair, then you may allow yourself to, as the expression goes, live to fight another day. So if you have someone who's older with comorbidities, then maybe you can limit your extent to the chest. Then that can make the world of difference for the patient in terms of recovery, multi-organ dysfunction, and so on. On the other hand, if you have a patient who is very young and has connective tissue disease, then you may not be doing the patient any favors by limiting your repair to something where you know the patient will be back very soon for a redo thoracoabdominal, which can be very challenging. So next is the branches. So that would be step 3. How are you going to manage the branches? So we have viscerals and renals to consider, and also segmental arteries to think about. And so the general techniques are you going to do a patch, which you can see here? And oftentimes you have to reattach this renal separately, or are you going to use a Caselli graft here, where you can individually reimplant each of the vessels? So when planning this, the considerations are your branches very far apart? So when you scroll through your CT scan, in your mind, you should be sort of constructing where the branches are relative to one another. What is that arc? Is it very far away, or are they all crowded together? And if you have 3D reconstruction of your aneurysmal aorta, then that makes it really easy. You can just pull back, look at it, and see, are you going to be able to group these branches together or not? Obviously, if you do, then that saves you quite a few anastomoses. However, there's the risk of patch aneurysm that you can develop later on. So for patients with connective tissue disease, that would not be a good idea. And generally speaking, for young patients with connective tissue disease, we would always individually reimplant each of the branches. So let's go back to our case. And I know, let's see who's on this call, and we can start picking on people. So let's see, Sophie. What would you do for the proximal anastomosis for the patient that presented?
Hi. Oh, sorry. There was both of us, I think, listening to the same call. All right, so for the proximal anastomosis, I'm not sure. So I don't know if I should pick on someone who's more senior to have them answer in my stead, okay. Or what the good call here would be. Do you want to
venture a guess?
Sorry?
It's not, I mean, don't feel shy. You can venture a guess, and then I can pick on someone else too.
Yeah, I think I'll defer to someone else if that's okay.
Oh, okay. Oh, yeah, of course. No problem. Does someone want to volunteer and answer before I pick on someone else? All right.
Well, sorry, I was just gonna.
Yeah.
Yeah. So I was gonna ask, just because definitely looking at the CT scan, you for sure looks like the arch is aneurysmal and most of the thoracic aorta. So most definitely, no matter what your proximal anastomosis is, you're going to be sewing to aneurysm, so diseased aorta. So that's something where I'm curious if you did a staged procedure here, or if you did just go right to the thoracoabdominal.
Yeah, it's a mega aorta. The whole thing was big. You're right. That's right. Exactly right. And what about Abigail? You're on a roll. What about distal?
So distal, I'd like to see the CT scan again. Actually, the rest of it was a little bit quick for me to see the.
I know it was a bit fuzzy.
Yeah.
It's not that challenging actually. The distal, it tapers after the viscerals, so you would sew in the infrarenal aorta there. And then the branches, let's just go to the next slide. So the first stage, absolutely, you're right, Abigail. So we did an ascending arch and elephant trunk, frozen elephant trunk, actually, to set us up for success for the actual thoracal repair. Distal was the infrarenal aorta. For the branches, she is not a connective tissue patient. And I know I'm sorry, I used my phone to record the CT, but the viscerals weren't that far apart from one another. So she was able to have visceral patch, and then the left renal was attached separately. We also did a bypass to intercostal artery. Okay. So next is end organ protection. And this is key to thoracoabdominal surgery. We have to protect all at the same time, the viscera, the kidneys, the brain, and very unique to this type of surgery is the spinal cord. So on the right here, this is the seminal series by Caselli, where he reported his experience, a phenomenal experience with thoracoabdominal aortic aneurysm repairs. And even for him, the spinal deficit rate was 9.6%. We're talking about, this is all extents taken together. The permanent spinal cord deficit rate was 5.4%, lumping together both permanent paraplegia as well as permanent paraparesis. There's a further 4.4% rate of temporary spinal cord deficits. And there's also a small rate of neurogenic bladder. And this is, of course, a very devastating, a life-altering complication to have. Besides affecting quality of life, it actually does have association with poor survival too. This is Cleveland Clinic endo data, but it applies for open as well, where if you do have spinal cord injury, this has a very, very significant impact on your long-term survival. So spinal cord injury is big for mortality as well as morbidity. So, and when it comes to aortic surgery, we do have to do everything we can to mitigate this risk, and that includes an understanding spinal cord blood supply. So you see here the anterior spinal arteries, the posterior spinal arteries, and they're supplied by these segmental arteries. And the classic artery to know about is the artery of Abdakowitz, which is supposedly the biggest segmental artery that you can see in most people. There's also an extensive spinal cord supply collateral network that exists in the spinal canal, the paravertebral tissues, and the paraspinous muscles. So all this area around the spinal cord is also rich blood supply, and they've been seen to adapt when areas of blood supply are compromised. So they've taken pigs, knocked off their segmental arteries, and then showed that all these collaterals will dilate and in response and take over the blood supply. When it comes to spinal cord physiology, the important factors for spinal cord perfusion pressure are your MAP, which are governed by the same things as MAP for all your CV-ICU patients, a heart rate, stroke volume, SVR, which we're all very familiar with managing, as well as CSF minus your CSF pressure. And CSF pressure is governed by your CSF volume, which we're familiar with managing because of we would drain it if the pressure was too high. It's also important to remember that it's also governed by hypercarbia, metabolic acidosis, and reperfusion injury. So these are other metabolic considerations that you have when you have someone at risk of spinal cord ischemia. What's also important is that if your CVP is through the roof, and some of these patients can have CVPs that are through the roof, they can be massively transfused and so on, that is actually then takes over this equation, and it becomes MAP minus CVP. So on one hand, you want to fully resuscitate your patients, but over resuscitation has a cost as well. So there are unfortunately many mechanisms of possible injury to the spinal cord during aortic surgery. You can decrease the perfusion pressure by having episodes of hypotension. If you have poor communication in the operating room, you have massive blood loss without a sufficient resuscitation from your team members, that can be devastating. Decreased perfusion pressure can also be caused by steel from back bleeding intercostals. So when you open that, your aorta, and you see all these back bleeding intercostals, don't be too laser focused on getting that anastomosis done right away. Take care of the intercostals because it's actively stealing from your spinal cord perfusion pressure. We obviously, when we replace large segments of the aorta, acutely disrupt the collateral circulation by the clamp itself and sacrificing the intercostals and lumbars. We increase ICP as soon as the clamp goes on. If you don't have any way of shunting off the blood proximally, your ICP is going to go through the roof. There's also ischemia reperfusion injury that starts as soon as the clamp is on. There are obviously mitigating factors. We use bypass machines and distal perfusion techniques to mitigate these. And then there's a decreased collateral circulation. So if a patient had previous aortic surgery, for instance, has the patient had previous AAA repair, then all those lumbars are also gone already. Was there a previous TVAR in this patient that covered the subclavian and the vertebral artery? That also would decrease your collateral circulation. And then finally, medical comorbidities, diabetes, age, atherosclerosis. This all impacts the amount of collateral blood supply that you have. So then, you know, all these mechanisms of injury. What are ways of strategies that we can employ to mitigate these mechanisms? So one way to break up thinking about it is pre-op, intra-op, and post-op. So let's see here now. So let's think about some preoperative strategies. Let's go to, I'm just going to pick people whose names I recognize, unfortunately. So Rachel, what are some preoperative strategies for mitigating spinal cord ischemia?
I'm not sure, Dr. Chung.
Okay. Oh, no problem. How about, does someone want to jump in?
I'll take a stab.
Okay.
Pre-op, I think at least at TGH, we routinely for thoracoabdominals admit the day before and put a spinal drain in, although that doesn't really make a difference for the pre-op. It's more for the intra-op and post-op. And I think maybe the most important thing is to optimize the hemoglobin of these patients and make sure they go in with a nice hemoglobin, which we need to maintain intra and post-op as well. I don't know if there's any specific other strategies.
Okay, very good. That's often missed. I'm glad that you said that. That's often missed, optimizing hemoglobin pre-op. Absolutely. What about, Roberto, continue. What about offer some intra-op strategies?
I think the spinal drain, of course, will be one of the main intra-op strategies. And I guess measuring reflexes, MIPS and MEPS, I'm not sure exactly how they work, but those would be one of the main things intra-op as well.
And also reimplanting your intercostals, like larger intercostals.
Okay. Mm-hmm. And post-op?
Good blood pressure.
High blood pressure, high hemoglobin are the main things, and frequent monitoring of neurovascular signs or neurological monitoring.
Yeah.
Neurosensory.
And I would say keep the spinal drain in.
Okay, all right. Thank you, Roberto. So these are some of the strategies that I came up with here. So preoperatively, patient selection. So I talked about all those comorbidities affecting your spinal cord. So select your patient wisely. Hemoglobin optimization, I agree with you. And we talked about whether there's compromise to your collateral blood supply. So can there be arteries that we can revascularize ahead of time, specifically the vertebral artery? Staging. We talked about the fact that collaterals can take over if you compromise the blood supply. So then one way of thinking is, well, if we gradually compromise the blood supply to the spinal cord, would that give the collateral network more time to react? So can we stage this operation? And then finally, minimally invasive segmental artery coil embolization is the same concept, where we knock off in IR with coils, lumbars and intercostals ahead of the surgery, so that it gives the collateral network a time to react. Intra-op communication, I think, is extremely key. Before you put the clamp on, before anything large is going to happen in the operating room, there has to be excellent communication to anesthesia and perfusion and nursing, of course. So I think that more than any other surgery we do when it comes to open TAAA repair, teamwork is paramount, and I really can't stress that enough. We also use hypothermia as a tool, and we'll go about, in more detail about that when we talk about distal perfusion strategies. Distal perfusion for sure. We talked about how when the clamp goes on, there's a lot of stress on the heart. There's huge preload now, huge afterload on the heart, and pressure that your brain sees and your spinal cord sees. So you're going to relieve that, right? So you're going to shunt that away to the distal part of your aorta, and that also, of course, it would then perfuse all the things that become ischemic when that clamp goes on. So distal perfusion is very important. Avoid steel. So we talked about how we would oversew those back bleeding intercostals right away. Segmental artery revascularization, somebody piped up and said that. Monitoring was also mentioned, and I put a question mark medical adjuncts, just like medical adjuncts aren't really aren't proven at all, and for circ arrest cases for arch repair. Same with intra-op management same with medical adjuncts for open TAAA. There's some evidence for pavrin use and things like steroids and so on aren't proven. Post-operatively, like Roberto was saying, you want to maintain MAPS, maintain your spinal cord perfusion pressure, get that drain in, lower your CSF pressure. You want to optimize your oxygen delivery, so optimize your hemoglobin, and these are the general strategies that we employ. So it's multimodal and throughout the patient's hospital stay, from the planning part in the OR and after the OR. So what's perhaps a little bit unique to open TAAA repair will be distal perfusion and lumbar drain. These are might be two things that you guys are slightly less familiar with. So distal perfusion techniques can generally be split into full and left heart bypass. So full cardiopulmonary bypass, I think all of you cardiac surgery residents are very familiar with. So I don't have to spend too much time talking about the setup for that. We would drain actually not here, but we would drain in the femoral vein and return in the femoral artery here, as you can see. And then for left heart bypass, the setup may be a little bit less familiar to you, where we drain from the oxygenated blood from the left atrium, generally through the left inferior pulmonary vein, and then we return it in the femoral artery. You can also return it in the distal aorta if you want. So what are our main differences? For full cardiopulmonary bypass, you would need, of course, full heparinization like you would with your regular cardiac cases. You also get the advantage of the pump sucker. So that's very nice. You're all very familiar with that. You can have lots of blood loss and have that just return to your reservoir and then back into your patient. so you can manage large volumes of blood loss quite nicely. The main thing is that it does afford you to have deep hypothermic circulatory arrest, so you can use full bypass to cool the patient down. And when we have no room to clamp and sew, and you don't think you can do that safely or well, then you can take the clamp off, like you can take the clamp off here, right? You can also just take the clamp off there, or not have a clamp at all, and do your anastomosis there. So having full cardiopulmonary bypass has lots of advantages. On the other hand, left heart bypass also has a lot of advantages. You don't need full heparinization. These are cases that require often a lot of transfusions. So if you can avoid full heparinization, that can save you a lot. And it's quite a bit faster and nicer if you can avoid it. Avoid deep hypothermic circulatory arrest. So if you can clamp and you can get away with just left heart bypass, that can be quite advantageous. It does mean that you need some sort of rapid infusing strategy. You can't just have a single single cell saver and hope that when you open up the aneurysm, the blood loss will be just managed by anesthesia. So we use a Belmont system at TGH to rapidly infuse the shed blood. Does anyone have questions about, we can save the questions for later. So CSF drainage, this is the setup here. Like Roberto was saying, we do place them in the ICU the night before. They're placed at L2 to L5. This is the end that goes into the patient. And then this is the drip chamber that it goes into. And then you can see that it's level to the patient. And then you can use this knob here to raise or lower the drip chamber to a certain height of certain centimeters of water or millimeters of mercury, which we generally use. And then every hour you can open up this and empty it into this bag, and then reset here, and then the drip chamber would be open again to the patient. You can hook up this end here to a pressure monitoring line, so then you can close it off to the drip chamber, and then it would just be the patient to the pressure monitoring line, and that's how you would measure the CSF pressure. So we generally set it up to 10 to 15 millimeters of mercury, and we're aiming for CSF pressures of less than 15 to 20 and CSF perfusion pressures of greater than 60 to 70. Is there evidence behind using CSF drains? The answer is yes, there is. So there's been one randomized controlled trial done in Houston for extents 1s and 2s. There were 156 patients randomized to using a CSF drain versus no CSF drain. And they were all set to 10 millimeters of mercury, and they generally removed them at post-op day 2 if there was no spinal cord ischemia. With this, they were able to drop their, with this, the group that had the CSF drain had a lot less paraplegia periparesis. So it was a 12.2% versus 2.7% rate, and that was statistically significant. This is data from Safi's group. Oftentimes when this is non-randomized data, and like I said earlier, spinal cord protection strategies are often multimodal. So he introduced multiple interventions at the same time in his practice. So that includes spinal drain, left heart bypass, and passive hypothermia, all at the same time. And with that, he was able to drop his spinal cord or ischemia rate from 7.5 down to the 2s, which is very impressive. So without these adjuncts, the 3 that I mentioned earlier, what he noticed was that paraplegia rate of paraplegia would increase with your cross clamp time. And this was particularly true for extent 2 repairs. However, if you used all these adjuncts that were afforded to you, then you can make your paraplegia risk actually rather independent of cross-clamp time. So if you use distal perfusion strategies, if you use passive with a left heart bypass and passive hypothermia with a lumbar drain, then you can actually pretty calmly and safely do your operation. Maybe not always spend 3 hours, but you don't have to sweat as much to sew as fast as humanly possible. So for the case then, what did we do to protect this lady? Well, we did hemoglobin optimization. She received IV iron before her surgery. She came in the day before surgery and got her lumbar drain. I decided we had the frozen elephant trunk there, so that was obviously going to be clampable. So we did left heart bypass that allowed us to have passive hypothermia. We managed the back bleeding intercostals and we opened the aneurysm sac. We used cold renal perfusion to protect the kidneys. Like Roberto mentioned, MEP and SSEP monitoring, we did that as well. And then post-operatively, we diligently managed spinal cord perfusion pressure. And with that, she did very well. There she is. She sent us a photo of how she's doing. This is the replacement of the ascending aorta, the reconstruction of the head and neck vessel, the Thoraflex frozen elephant trunk, and you can see how it's been anastomosed to this graft and sewn here at the distal aorta. And thank you very much for listening. And I'd be happy to answer any questions or defer to the panel for that.
Dr. Chung, this is Rashmi. Thank you. That was wonderful. I feel like because I've been with you at the center for a while, I feel like every time I hear you talk about this, I learn more and more. It's really lovely. I was wondering, when you had spoken about cold renal perfusion, I was wondering about the other organs, about visceral perfusion using cannulas, and when you choose to do that, and risks and benefits.
No, that's a very good question. So with the left heart bypass machine, you can actually Y off of it, and so we have perfusion catheters that come off of our arterial limb that we can just then put directly into the visceral vessels. So that's how we perfuse those.
Okay, thank you.
Yeah.
And you have 3 or 2?
We used for the viscerals, for the renals, so 2 for the viscerals, and then for the renals, we use cold renal. So that's on a different circuit.
Okay, thank you.
Yeah, no, that's good. Cold renal, we use cold crystalloid because there was actually an RCT on that as well for cold crystalloid versus warm blood.
Okay.
And cold crystalloid did better.
I just also want to, this is Saurabh here. I just want to reiterate, first off, thank you, Dr. Chung, for the lecture, but also our panelists, Dr. Ozunian, Dr. Herman, and Dr. Moon, like Abby mentioned, are on the Zoom call as well. So if they want to chime in to answer any of the questions, that would be fantastic as well.
Yeah, thanks, Saurabh. I was going to ask Chris and Mike how they would have handled this case in Halifax and Edmonton. What surgery would our lovely woman have gotten there? Chris, do you want to go first?
Yeah, sure. I mean, I'd have to see the scan again. I don't think we would have done it much different than you guys, but except for we tend to favor cardiopulmonary bypass and circ arrest in Halifax versus LAFA. Unless there's a really obvious, easy clamp site distal to the subclavian. And that's for a few reasons. One, you can cool, as Dr. Chung mentioned, on cardiopulmonary bypass, which you can't really do on LAFA. And the management of blood pressure is a real dance between perfusion and anesthesia, unlike cardiopulmonary bypass. It requires a lot of communication. And if you're not doing it a lot and don't have experience in the room in that regard, it can be not the best. So we tend to, in Halifax, maybe favor that unless it's a slam dunk. The other thing I was going to say is that there's almost always somewhere you can sew to. I mean, this is a mega aorta. It's a bit different, but in like traditional atherosclerotic or whatever age aneurysms, there's always somewhere you can sew to, either in the arch or in the abdomen, to stage the procedure. So Halifax likes to stage the procedures as much as we can. So is not unfrequently we'll sew to a 4-point low, something like a 4.0 or 4.2 centimeter in the distal chest, and then stage it a few months later and come back for the abdominal component, especially if it's an extent 2. And this is really nice because it allows re-collateralization for the spinal cord. And we've started to do that wherever we can. So that would be something else kind of that to consider when you can.
So left thoracotomy first, and then come back for a lower thoracoabdominal.
Yeah, we've done it both ways. We kind of operate on whatever is screaming at us the loudest. So if it's a big, we had one Marfans actually who had a really big abdominal aneurysm. So we did that first, and then we came back and did the thoraco. And sometimes, like for one, we actually left a little space in between the two because there's some big spinals there, knowing that we could go stent graft to graft if that became a problem in the future. So you know, that's the other point, is this, that every patient is unique and you have to have a really versatile kind of strategy for every single person.
Yeah, often, you know, sometimes they are sort of two distinct things and not just one giant contiguous aneurysm. So would you use left heart bypass with an elephant trunk, or are you guys just like full cardiopulmonary bypass as a rule?
Well, we don't do a lot of elephant trunks, to be honest with you. We don't use the Thoraflex a lot. We like the little, my residents are on the call. What's it called again? The little 3-branch graft there. Spielvogel. Thank you. Thanks, Joel, or whoever that was. We like the Spielvogel graft, and then debranch the head vessels and or do a carotid subclavian bypass, either preoperatively or like, you know, in another stage, and then set a landing zone for a T-bar right in the arch, which has negatives and positives, but that's kind of just what Halifax does.
Cool. Mike, what do you think?
Yeah, I enjoyed Jen's talk very much. In Edmonton, my personal practice is to try and use the heart-lung machine as much as possible, mainly to Jen's point of being able to manage volume, blood volume. When I was a fellow, we used LAFA all the time. In Winnipeg, we didn't actually have at the time when I started my practice there, we didn't have the level 1 or the Belmont rapid infusers, so it got quite nerve-wracking trying to manage volume losses. And I don't find that full heparinization is too big an issue. I don't think bleeding post-operatively or at the end of the case is what I'm usually worried about. So full heparinization, even if we have a place to clamp, I like having the reservoir, I like having cardiotomies. You'll run partial flows with a clamp on, and then I can still do distal perfusion. You can let the patient drift. You know, obviously you don't want them too cold so they'll start fibrillating, but my general preference is to use a full cardiopulmonary bypass, have reservoir, have the pump suckers, and then have the option of trying to control the temp of the patient a little bit. And when we are doing extent 2 then and not circ resting, then as you described, you can always run off your circuit or run off the cardioplegia pump head, multi-perfuser, and then be able to deliver blood, tepid or cold blood, to the visceral vessels.
Oh, I'm muted. Thanks. Any of the residents somewhere where they do left heart bypass, or is everyone doing full pump for these? I see no faces because everyone has their cameras off, except for the panel. Let's see some faces. Who's seen left heart for this?
I was just gonna say, yeah, it's not because the only thoracoabdominals I've ever seen were with Dr. Moon and Dr. MacArthur, and so yeah, I would say the ones that I have seen, we've cooled to 18, full heart bypass, and we've put in an event. So it's sort of it was awesome to see the lecture and hear about how it is such a variable practice across Canada for sure. I think.
Well, for you, Abby, the next time we have a thoraco, if it's appropriate, we'll use LAFA bypass. We'll do that for you.
Thank you. I appreciate that.
That is excellent teaching staff that you have there, changing his practice for the
resident.
Yeah, I love it.
It's Rashmi. I'm here in Toronto, and so I guess all I have seen is LAFA. Actually, I haven't really seen a lot of cardiopulmonary bypass. But I did. I mean, I don't have that much experience with it, but I do fully recognize the kind of dance that has to take place. Like the perfusionist has to always be thinking, because like sometimes you don't need LAFA at all. Sometimes it needs to be like turned way up. It depends on how like the map in the brain and the lower body is behaving, and if it's volatile or changing, like they do have to be really present. So would you say, Dr. Izuni and Dr. Chung, that it requires more, I don't know, more present and astute personnel to be able to use LAFA?
Yeah, I would say for sure the team has to be awake and really managing it. There's no big reservoir. I remember Caselli telling a story that he had to go to Russia and do some thoraco, in the 80s or something, or not maybe a bit later in the 90s. And he wanted to do left heart bypass, and they didn't have a Belmont, and they just had some terrible suctioning device. And the Belmont is really crucial. You press a button and it can infuse volume at 500 cc's a minute. So it just, it just gives all the blood back that you're getting out of the patient. So he did this case, tried to do it with left heart bypass, and the patient almost died. Like, they didn't know how to do left heart bypass. There was no Belmont. The patient almost exsanguinated and so on. So it's really, it needs a lot of communication. And I guess, we sent the team to Houston, actually, two perfusionists and two anesthetists to pick it up and bring it back here. So it sounds like most people are doing full pump. We like it whenever, at least when you can clamp the aorta.
Yeah, as a fellow, what we did in Cleveland is they didn't use Belmont or level 3 at the time, but they just ran a cell saver off the bottom of the reservoir of the cell saver. They ran a 1/4-inch tubing to a pump head, and they just infused it right back into a huge subclavian line. And they had a filter. They just put a filter on it. You obviously had to watch the volume in the reservoir to make sure that you didn't run it dry. But a huge part of these cases is not just the surgeon. Like, you have to have the right anesthetist. And when I was in Winnipeg, we had of the 10 anesthetists, I only did my major aortic cases with 4 of them. We were on the same page. We always had a plan. It was never a surprise in terms of did you forget to get us an extra line just for volume resuscitation? So I think that as much as you plan the case, you can be undone by your anesthetist or your perfusionist if they're not on board. And at the very beginning of my practice, both in Winnipeg and when I moved to Edmonton, I spent a lot of time talking to the anesthetist and the perfusionist before we even started the case, typically the day before, to let them know exactly what the conduct would be. And I think that that's an incredibly important point that you're going to want to do, because you don't know where you're going to end up. You're not going to work. You may not end up at TGH where the support team is going to be fantastic. If you end up in small podunk hospital where they've never done one, and for whatever reason you want to start doing them, you're going to have a lot of other challenges that you're going to be faced with.
And just kind of I don't know, logistic question, because it's definitely different here in Edmonton than I know at some other places, but vascular surgery involvement, how much of these cases, and obviously it depends on, I'm assuming like the extent, but what is the relationship like elsewhere and vascular surgery involvement?
Do you want to take it, Jen?
We work very closely together. We have a shared aortic clinic where we evaluate cases together and do case planning together in terms of what approach we're going to take. Is it going to be open, endo, both? And then intraoperatively, we combine the cases as well. So I think we work very collaboratively together here.
For sure. And Christine is vascular, so she just needs
He
her.
is both.
So yeah, both the aortic surgeons Halifax are both vascular trained.
Jeremy also, yeah.
And have vascular days. So we both do have a full vascular practice. But Mike Moon just typed that 2 surgeons is ideal, and I can't support that enough. I mean, whether it's vascular surgeons or whoever, if you're one cardiac, one vascular, that's great. I think having an extra brain in the room is always great. It doubles your experience in the room to have people who are doing it with you. And actually what Jeremy and I have started doing, which is really nice, is we'll split the cases. So like one of us will start the incision, and then the second person will finish the case. So the other person's home having supper while the other person's mopping up. So sometimes that's nice too.
I like that idea.
Yeah.
So all I need to do is buy you a ticket. You can fly in and finish up you can mop up.
Sure. Yeah. But you
available.
have to alternate first surgeon with me for billing. That's all.
Okay, that's fine.
What about you, Mike?
In Winnipeg, I did all my extend 2s with vascular surgery. In Edmonton,
Did we lose Mike?
Yeah.
Yeah, it looks like he's frozen there. Basically, I guess in Edmonton, it's Dr. Moon and Dr. MacArthur. And then I do, vascular surgery sort of does their own cases, and it's not a very, it's definitely not linked.
Do they do extent 2s also, vascular? Or just
Yeah.
2s as well? And okay, yeah.
But
we're pretty lucky.
Oh, sorry, go ahead. Yeah.
Go ahead.
No, yeah, I was just gonna say it's been I think they're like historical issues, but it sounds like that seems like a really good working relationship that you guys have at TGH. And obviously Dalhousie having cardiac surgeons as vascular surgeons as well is super nice.
Well, actually, I was just going to say, I mean, you guys are the new generation. And so it's time to get rid of all that toxic, not working in multidisciplinary teams. In Halifax, we have a very unique situation where the vascular, cardiac, and interventional radiology for vascular get along very, very well. And most of these cases, even if we know they're going to be open, we'll be like, hey, look at this case. What do you think? And we'll talk about it. And every once in a while, someone will be like, oh, you should use a Medtronic instead of the Cook, or why don't you try fenestrated for the distal, or whatever. I think it's a really, really great approach. And we actually have interventional rounds on Thursday mornings where sometimes we present these cases informally. And it's just a really great way to work.
Yeah, I think we're pretty lucky here. Jen and I spend a lot of time with Tom and Tom.
The Toms, yeah.
The Toms, we see them, usually more than our own partners, to be honest. And we do clinic together and case planning together and cases and stuff together. So most of these patients get vetted by at least the 2 disciplines, which is good. It just gives a different eye and a different flavor to it. And everyone has a slightly different skill set. I mean, Jen's trained in open and endo like Christine, but it's still nice to have a different perspective on it. Tom's done a ton of fenestrated and branched, not a ton, but for as far as Canadian experience goes. Yeah.
So does anyone else have any other questions? The other trainees or anything? Doesn't look like it. Well, thank you.
Oh, sorry.
Yeah.
I was going to ask if you wanted to keep going or if you wanted to thank everyone. I'll let you finish.
No, go ahead.
I just have one question for the panel. it's more from a practice perspective in terms of volumes. What you think is kind of the minimum open experience you need on an annual basis to be able to say, we keep our skills up and expertise up, and what kind of volume you guys are seeing at your centers on an annual basis. More from a future career planning perspective to give us all an idea of what's needed to sustain a practice.
What do you think, Chris?
Well, I don't know the answer to that question. I think that is part of, we probably do, I don't know, maybe the residents would know more about how many we do, but we probably do 12 a year, 20 a year, maybe something like that. So probably definitely not as much as TGH, but that's the benefit of scrubbing in on all of them if you can, because then you're, instead of splitting the practice with your partner, because then you get all the experience that you can. And that's just open that I'm referring to. But we also do a lot of open AAAs and type 4 AAAs. So I don't know where those kind of fit into the whole picture. But one of the things that benefited me, I'm sure Jen will say the same, is being a junior attending and having being able to scrub in with senior or attendings like Morale, Dr. Zunian, and myself.
For
yes,
sure.
So senior.
Oh my God, for sure.
And myself with Dr. Wood to kind of mentor you. I think that's a big thing, because some of these cases can be really big, and like all of a sudden you're an attending, you're like, oh my God, how do I position this patient for a thoracoabdominal, right? Like you kind of miss that, right, in your training. So
you can get into a lot of trouble with these cases. Let me tell you, a lot of trouble. So it helps to have someone with so much experience as Dr. Zunian to be in the room with you.
It's just good to have an extra brain in the room, to be honest. I love it. I love having Jen or vascular, another surgeon in the room, I think is really, really key. In terms of volume, I think they're like even Houston, the open thoraco volume's down. It's a lot down compared to when I was there. And in the heyday, they would do 150 up to over more than that a year, huge amount, like three a week kind of thing. And I think you need to do at least like 1 or 2 a month, I would say, just to kind of keep the team engaged and active. And it's more also the infrastructure in the ICU, to the first few years was a lot of, trying to get the nurses on board and the ICU on board and so on. But I think it does need a core minimum volume for sure. Of course, all the other aortic stuff we do helps, but this is it's just a different ball game. So if you're doing only 1 a year, you're not going to remember what you did, last year when you did it. Mike, what do you think?
Mike's back. So the question was volume to sustain a thoracal practice.
That's a good question. I think we don't do enough in Edmonton. I think I would definitely feel more comfortable doing more cases, but I think at the bare, ideally you should do at least 1 a month. But the difference is, it depends on how much aortic surgery you're doing overall. I don't think the limiting factor is usually from the surgeons, but my big concern is about the perfusionist and anesthetist. Like I'm honestly, if I go 12 months between a thoraco, I'm totally fine from my perspective. Maybe it's a bit cavalier to say that, but my biggest concern is the ability of the perfusionist and anesthetist to be there. And anytime we have a case we're taking down the diaphragm, I'm always having a long talk with the people that I'll be working with. I want to know who my anesthetist is before we get to the room, before the day. I want to know who my perfusionist is going to be, because that's where we're going to run into issues. Between Rod and I think we're pretty capable of doing the surgical aspect, but you have to keep the numbers up for your team. It's no different than if you're only doing 1 Bentall, 1 Bentall a month or 1 Bentall a year. Obviously the proper answer is more the better, but you have to think about the people you're working with.
Actually, I did have another question. I had forgotten to ask about it. But so again, in Edmonton, and speaking to both Dr. Moon and Dr. MacArthur, the preference when we're talking about branch vessels is to do them all the individual anastomoses rather than the patch. And obviously recognizing connective tissue disease being a factor for patch aneurysm and not being a concern. But I guess I'm just asking the panel here, what in a non-connective tissue disease patient, what is the largest patch that you would consider doing? Or like, do you have sort of a, I don't know, like a grading scheme that you're looking at before you choose to do a patch, or just do all of them individually?
Jen, what do you think?
So if they're, like I said in my in the presentation, if they're really crowded together and they look like naturally they want to be a patch, then I think it would work. So I think for her it looked that way. You look at it and it's crowded together. She's a 70-year-old lady. She's not connective tissue. What are the chances that when she's 80, I'm gonna be worried about it? So that is one thing. But I also enjoy individual implantation. Sometimes the aneurysm is so big and it stretches out. Now your vessels are here, 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 here. And that's a ridiculous stretch to make. So then I feel like it's a bit of an art in terms of how you want it to look at the end. I say that I don't know if Dr. Zunian would agree, but I feel like we do both. And it's rather than all one or all the other.
I don't think there's a magic number, Abigail, of like dimension or size or something. You just have to, we see it on the like a reconstructed CT and imagine what the patch would look like. And if they're this, super far apart, then they're getting branches for sure. Or if they're really young, if they're in their 40s, even if they're not Marfan, something's going on, and we know they have to live with this for much longer. Their risk of reintervention is higher, so low threshold for a branched graft in that setting for sure. And the branches are fun because the fellow, someone else we get to pass them off. Chris, what about you?
Yeah, I think we like to do individual branches because, like Jen alluded to, sometimes it can be an art. So if you're only doing one a month, it's nice to kind of always do it the same way. You can start reperfusing your viscerals as you're doing it. We also do our intercostals with a 10 millimeter side arm branch, which is really nice. And you can actually reperfuse the spinals while you're sewing. We'll just put like a perfusion candle in there and snare it down so that the spinal arteries are perfused as well. I think probably the time we would do a patch is in someone who's older, but I tend to not like doing thoracoabdominals in older people, and we'll find almost a hybrid solution if I can, as much as I can. The other thing not to forget that I actually like to do is a really aggressive bevel. And so that is also for maybe the older patient or someone maybe you're going to be coming back into the future. So you might have distal perfusion and then you turn it off and you just kind of bevel your anastomosis down behind the visceral vessels. So the front is kind of aneurysmal as it would be in a patch, but you've avoided having to re-anastomose everything. So that's a nice option too.
Chris, what do you use for the intercostals when you
just a 10 millimeter Dacron sidearm.
So you sew it as you're going down, like in the midsection, as you're going down the aorta, put it on first and then perfuse down the graft. Is that what you mean? And then put it onto the graft at the end.
At the end. Yeah. While you're rewarming.
Yeah, cool. Yeah, we often do the intercostals with a graft as well, but we haven't been doing it sort of as we go down. We just, leave little baby ducks or something on them or little perfusion occlusion.
Yeah, we've done that too.
And then put it on at the end, just to not think about it while the clamp's on, but you're getting blood back to it if you sew it on too, so.
Yeah, and it depends too. Like I think in the day where we would not have had distal perfusion, we wouldn't have done it that way. But now we always Y off our cannulas and have distal perfusion going, which I think is important for the spine as well, because there's always collateral systems from the pelvis and internal iliacs and things like that. So
I remember Jeremy doing a lot of like PA, left subclavian artery cannulation. Is that still, you guys still do that? Or is your bypass circuit mostly like fem bypass for full pump?
Yes, sometimes. I probably less doing the subclavian artery, still the PA sometimes. The PA is nice because, well, you can do this with fem too, but run the pump and fill the heart up so that there's no air coming into the heart. So we do that sometimes. It really depends on the case. But I think we've been doing less PA subclavian than we did in our training time.
Cool. Mike, what do you do for intercostal reattachment?
If they're a mid-age person and not too old, I would probably just put a patch on. If they're younger, I have put 8mm grafts or 10mm grafts to a pair of bevel it and just try and grab the biggest pair that you can. But as Jen mentioned, I try and oversew as many of them as I can as quickly as possible.
Mike, do you also do fem-fem?
Yes. Okay. Yeah, fem or femoral venous drainage, and if sometimes I will cannulate the descending thoracic, but usually femoral arterial would be my preferred way of doing it.
Okay.
So then, someone will do femoral cannulation, sew an 8mm graft on, and someone else will open up the chest and start taking down the diaphragm. And that, again, obviously you can have a fellow or help you with that, but if you have, 2 surgeons and a fellow and an assistant, you effectively have 2 surgical teams, so you can work in 2 different locations. So while you're, if you are planning to cool, it is nice to get on bypass as quick as possible and start cooling. And I don't hesitate to fully heparinize a patient, start cooling before the chest is open, to start making use of that time. And then while we're cooling, we will take the diaphragm down. I know Rod is the opposite. Rod likes to get all his dissection done before it's heparinized. He'll expose absolutely everything, and then we'll go heparinize the patient at that point, cool, so then you can go for coffee, come back in 90 minutes, and then do your case at that point. But it works.
This session is recorded, Mike.
That's okay. That's okay. I say that right to his face, so I'm not saying anything that I'm not comfortable saying.
Oh, right. This is getting posted. I forgot about that. Yeah. Mike, are you dividing the diaphragm all the way down to the aorta, or leaving, Caselli would expose everything, but we've been leaving quite a bit of diaphragm intact to try to, and just working around it. And it's not that bothersome. And I think it's better for the pulmonary function.
Yeah, I still take the diaphragm right down, like the hiatus right.
Oh no. He's frozen again.
Oh no.
I'll probably leave a rim that maybe I'll leave enough to be able to sew it down, sew it back together. But it's as long as I have enough aorta, like a cuff of aorta, to sew it back together on the Dacron graft afterwards, I'm pretty happy. But I makes exposing the celiac artery and the SMA a little bit easier.
Mm-hmm. Well, we open it from the aorta at the hiatus upwards, but then, and also at the costal margin, but then we leave a good, big chunk and just put a tape around it, and it's quite mobile and not too cumbersome, actually. Yeah. Chris, what do you guys do for the diaphragm?
So you don't split it all the way. Yeah, that would be nice. I think that's why, like, when we're saying we're staging it is nice, because then you tend to take down the diaphragm as much. And I think that's better tolerated in patients. So I think anything you can do to spare the diaphragm is nice.
Mm-hmm. Mm-hmm. Anyone doing spinal cord embolization pre-op?
Yeah.
Not yet, but I'm super tempted. I think the next time I do one, I will have IR do it. They're prepared to, and I think they're very interested in doing that.
So Christine, you do for open as well?
We've done it once or twice, and I'm going to be honest with you, I don't remember what the case was.
Yeah, I think they started here with the endo cases, but we just started doing it for the opens as well.
I think we were doing it for one of them was for a hybrid kind of scenario, which is nice. Like it was a distal open. So, I mean, you still sew the aorta down to the graft before you sew it onto the distal graft, but at least you know you won't have, you might not run into the back bleeding issue of the spinals.
Mm-hmm. Yeah, for sure. If there's an elephant trunk or a frozen elephant trunk there, and your thoracotomy is not that high, and you don't have any, clamps up there, it's sometimes a nuisance, the back bleeding from the top, for sure. I think we've done it in a 2022, mostly endo though. And just a few open, but I think it's a interesting approach. The IR people complain about it. It's not the easiest. It's not actually the easiest technique to get in and embolize. A few of ours are particularly quite good at it. But I think the more people do it, the better they'll get, for sure.
I think that one of the worst complications for patients is paraplegia. So anything you can do to stage your procedure or minimize or gradually start taking off the spinals, anything you can do, always revascularize the carotid subclavian if it's not an emergency. And we look at the internals as well. Like you're not going to go open internals up, but at least you know that may increase your risk of paraplegia towards the patient, so you can have a different conversation with them. And I mean, every little thing you can do to prevent paraplegia, you need to do it. Except for reattach all the spinals. I hate doing that, but
I know. I think that's a super important point, Chris, for sure. Yeah.
Thanks very much, Abby.
Okay. Thank you, everyone. Really appreciate your talk, Dr. Chung, and I think Saurabh wants to say a couple things.
Yeah, I just want to thank everyone for taking their time. I'm sorry I don't have a video on. No one needs to know what my face looks like today. And I just wanted to thank Dr. Moon for starting us on our aortic block, and then Dr. Azinian and Dr. Chung for continuing it on and finishing it up. I'm sure all the trainees as well as surgeons who sign on have really appreciated it. On behalf of Abby and myself and CSCS, thanks a lot. We also just want to advertise that next month we'll be talking more specifically about the aortic valve and the root. So starting February, we'll kind of shift focuses. And so our first lecture will be by Dr. Richard Whitlock from McMaster, who will be talking about valve sparing root surgery. We'll send out the dates and the times once everything is confirmed. So yeah, just thank you everyone, and have a good night.
Can I just say also, Abby and Saurabh, I think you guys already know, and probably most of you know, about the CSCS Resident Research Day. Has everyone gotten an invitation to that and submitted abstracts and so on? It's Terry Yao's brainchild, and it's a cross Canada research competition. Obviously, it's virtual this year, but it's reminiscent of what Terence Donnelly Day was back in the day. And so I think it's a really, it's going to be an excellent opportunity. He has some cool speakers. I think Paul Fidak is doing the scientific talk, and there's some cool other second thing happening. So try to join. There'll be send emails if you don't have the invitation yet, but it would be great to see everybody there. It's in February. Do you have the date? Does anyone know the date?
I have the date. Just 1 second. I was going to bring it up.
The 27th.
Yeah, I think you're right, Vincent.
Okay, but keep an eye out for that for sure. It's a Saturday.
Yeah, it's 27th on Saturday. Yeah,
it's the Saturday 27th. And the second thing that Dr. Azuni is talking about is the talk from Brian Ferguson, who's the lead of Arena Strive, talking about sort of basically surgeons as high performance athletes and high performance careers. And I'm sure some of the senior residents got their emails. Dr. Yao was looking for participants from senior residents across the country. Basically, you get a strap on your upper arm bicep that records your sleep patterns, your heart rates, and things like that. And it's kind of interesting because as long as I've had it, it keeps telling me I'm falling behind in my sleep. Which I didn't realize I needed a strap to tell me that, but it is interesting because you realize that the more intense cases you're doing, your heart rate does tend to fluctuate and your strain levels change throughout the day. So I urge all the senior residents to get back to the team and get back to Dr. Yao and sign up for the study and help them out, and it'll be a great talk on the 27th.
Fantastic. Awesome. Great to see you guys.
Thanks, everyone. Take care.
Thank you.
Thanks, Jen.